The following podcast is part of a certified educational activity titled Targeting BTK, the latest data on the evolving treatment landscape for patients with MS. Access the entire activity and complete the post-test at peerview.com/TFV860. Downloadable slides are also available.
Hello, and welcome to this educational activity on BTK inhibitors as a potential treatment for multiple sclerosis. I am Dr. Daniel Reich. I'm participating in this CME event as an outside activity and not as part of my official capacity at the National Institute of Neurological Disorders and Stroke at the National Institutes of Health. Our goals for today: to enhance your understanding of the mechanism of action of Bruton tyrosine kinase inhibitors in the targeted treatment of multiple sclerosis, to update you on the current evidence coming out of the clinical trials, and to help you consider which patients may benefit from treatment with BTK inhibitors based on current evidence and individual treatment needs and priorities. The multiple sclerosis lesion in the brain or spinal cord is a complex thing. There is a plethora of cell types, including cells of the brain and cells of the immune system that are interacting in complex ways. And we understand that the pathogenesis of an MS lesion in terms of how it forms and how it resolves and hopefully how it repairs depend on this interplay. And principal drivers in the immune system include T cells and B cells, and in the immune system of the brain, the innate immune system of the brain, the microglia, in concert with a whole host of other cell types. So what is the rationale for BTK inhibition in multiple sclerosis? BTK is expressed in most immune cells, in particular for the purposes of multiple sclerosis, in B cells and in the microglia of the brain. In B cells, it is located downstream of the B cell receptor, and in microglia, downstream of the Fc gamma receptor. And in B cells, inhibition of BTK would be expected to slow maturation of B cells, to reduce their proliferation, ultimately to reduce autoantibody production and to decrease cytokine secretion. Whereas within microglia, again, the innate immune cells of the brain, BTK inhibition would be expected to decrease their activation and to diminish their pro-inflammatory cytokine secretion. And it would also thereby have impacts on cell-cell communication, which may be relevant for the development and repair of multiple sclerosis lesions. So with all of that, what can we say about the potential advantages of BTK inhibitors in MS treatment? Well, multiple lines of evidence show that chronic neuroinflammation that contributes to disability in both relapsing and progressive MS is associated with B lymphocytes and microglia in the central nervous system, as I've said. BTK regulates B lymphocytes and myeloid cells and is therefore a logical therapeutic target in MS, as well as in other autoimmune diseases potentially. And unlike MS therapies that act primarily outside the CNS, most of our, in fact, all of our approved disease-modifying therapies, some BTK inhibitors have been demonstrated to cross the blood-brain barrier and can even reach therapeutic concentrations within the brain and spinal cord. And so BTK inhibition may have a double mode of action, both in the periphery, in the peripheral immune system, and within the CNS itself. Comparing both BTK inhibitors and CD20 antibody therapies will be expected to impact B cells, of course. And we know that B cell depletion via anti-CD20 monoclonal antibodies substantially, even dramatically in most cases, reduces MS relapses, as well as the new lesions or new plaques that develop and are visible on MRI as measures of activity. And though there are data, certainly, and an approval for CD20 inhibition in modifying progressive MS, the impact on progression and the biology associated with progression, including chronic inflammation, is overall less clear than its dramatic impact on the formation of new lesions and relapses. BTK inhibitors are expected not to fully suppress B cells, but to modulate them and to modulate their functioning without creating a true immunodeficiencies. And so there may be some safety advantages to using BTK relative to CD20 monoclonal antibodies. So one of the concerns with current MS treatments is immune suppression, in particular around B-cell suppression and elimination with CD20 inhibition using monoclonal antibodies. There are concerns with respect to infections that can occur, including common infections and potentially poor outcomes in COVID-19. You can see hospitalization data here on the right relative to glatiramer acetate. And it's possible that because BTK inhibitors are not depleting of B cells, but rather immunomodulating, that the infection data may be more favorable, and that is something that the large trials hopefully will inform us about. So we know that in multiple sclerosis, thinking about the pathophysiology of MS, that inflammation and axonal loss and subsequent neurodegeneration are intimately linked. Inflammation manifests most clearly as new lesion formation, which we see on MRI, and a portion of those new lesions are the basis for clinical relapse. And these are most frequent early in the disease, and they become gradually less frequent over time, even in the absence of treatment as patients age. And at a certain point in most patients, secondary progression takes over, at least as the dominant clinical picture. But we know that there is axonal transection and neurodegeneration that occurs from the very beginning of the disease, and it may not manifest as clinical progression until it crosses some threshold. And we know now, and we understand that much of that neurodegeneration occurs not temporally linked with the acute inflammation, the new lesion formation, but may have a basis in chronic non-resolving inflammation that occurs in the brain that may not be targeted by peripheral immune modulation, such as with CD20 monoclonal antibodies or the other disease-modifying therapies that we have. So what do the trials reveal about BTK inhibition? So there are a number of BTK inhibitors in clinical trials for multiple sclerosis, 4 of them in phase 3 studies: Evobrutib, Talibrutinib, Fenebrutinib, and Remibrutinib. And to date, only data from phase 2 trials in Evobrutib and Talibrutinib are available and in published form or in presented form. And you can see that these BTK inhibitors differ in terms of how they bind to BTK, either covalent or non-covalent, and in their reversibility. So let's discuss the data with respect to Evobrutib. Evobrutib is the first of the BTK inhibitors for which we have data in multiple sclerosis. Here's the design of the phase 2 clinical trials of Evobrutib. This study enrolled patients with relapsing, remitting multiple sclerosis or secondary progressive MS with ongoing relapses into one of 5 arms: a placebo arm, which after 24 weeks transitioned to Evobrutib 25 milligrams, 25 milligrams of Evobrutib from the get-go, 75 milligrams once a day, and 75 milligrams twice a day, with an active control of dimethyl fumarate also followed. And these were studied for 24 weeks with a blinded extension out to 48 weeks. The primary outcome was MRI, the number of new gadolinium enhancing lesions but other outcomes, including T2 lesions and gadolinium-enhancing lesion volume, were also studied. And annualized relapse rates and EDSS, the disability scale, were also looked at. After the trial was finished, there was safety follow-up and open label extension, initially with 75 milligrams daily, which changed to 75 milligrams twice a day after 48 weeks. And here are the primary results showing a reduction in the number of gadolinium-enhancing lesions at the 75 milligram dose and trending at the 75 milligram twice a day dose. Treatment emergent adverse events, including grade 3 and serious treatment emergent adverse events, were comparable, but a bit higher with 75 milligram twice a day dosing, driven by asymptomatic increases in liver transaminases. And we'll come back later to talk about liver issues with respect to BTK inhibition. And there was evidence of a dose-response relationship with Evobrutib. The annualized relapse rates were lower in Evobrutib at 75 milligrams and 75 milligrams twice a day than in the placebo group, and comparable, I think, to what was observed with dimethyl fumarate. Again, the total number of gadolinium-enhancing lesions and new and enlarging lesions compared to placebo was reduced on the higher doses of Evobrutib. And another interesting and important MRI measure was looked at subsequently in Evobrutib-treated patients, and these are called slowly expanding lesions or sometimes slowly evolving lesions. This reflects lesions that are dark on T1 weighted images, hypointense relative to brain, that are gradually enlarging over time as judged from a combined analysis of the entire trial MRI data set. And these are thought the basis of slow expansion of lesions as visualized in this manner is not entirely known. However, it's been hypothesized, and there's some data to corroborate that it may be a reflection of chronic inflammation in the brain. And in this early analysis, there is a trend toward a reduction of the slowly enlarging lesion volume at the highest doses of Evobrutib. At the 2023 American Academy of Neurology meeting, the efficacy and safety data of Evobrutib over 3.5 years in the long-term extension were studied. 72% of patients, or 155 patients, completed more than 228 weeks of treatment. This is more than 4 years, so the combined 48 weeks in the double-blind period and the long-term extension. The pooled annualized relapse rate remained low at 0.13 per year, supporting the phase 3 clinical trial dosing regimen, and that's currently ongoing. And then the rates of serious treatment emergent adverse events and serious infections in general were relatively low, and in the long-term extension, no new safety signals emerged. Also at the 2023 AAN meeting, additional non-clinical data for Evobrutib were presented in comparison with CD20 inhibition in mice with experimental autoimmune encephalomyelitis, or EAE, suggesting that there may be impact of Evobrutib on CNS inflammation that is not achieved with B-cell depletion therapy. And then finally, also presented at the 2023 AAN meeting, neurofilaments in the serum were looked at over the long-term extension, and neurofilament levels declined in the trial, and this was associated with improved MRI and relapse outcomes, again supporting the role of neurofilaments as a potential prognostic marker for disease activity in the setting of BTK inhibition. I'll now summarize data from the trials of the second BTK inhibitor for which data have been presented and published, and that's Talibrutinib. Shown here is the design of the phase 2 dose-finding study for Talibrutinib. This was a study of patients with relapsing multiple sclerosis with EDSS between 0 and 5.5, and they were adults. They had to have evidence of a history of relapse in the past 1 to 2 years or of new lesions on the MRI. This was an interesting study that had a block design. 4 doses of Talibrutinib were studied either initially after randomization or after a 4-week placebo run-in, and those who got Talibrutinib in the first block, both of these blocks were 12 weeks, were then transitioned to a 4-week run-out. At this point, the long-term extension study began, and patients were maintained at the dose that they had been randomized to during the double-blind period until the final dose for the phase 3 studies, which was 60 milligrams per day, was selected, at which point everybody was transitioned to that dose, those who remained within the study. MRIs were performed every 4 weeks in the double-blind period, and then at lower frequencies in the long-term extension study, which is still ongoing. And with respect to the primary outcome of the phase 2 study in Talibrutinib, there was a dose-response effect showing a reduction in new gadolinium-enhancing lesions in the brain as the dose of Talibrutinib increased, with a relative reduction of 85% in the 60 milligram dose after the 12 weeks of treatment. At the AAN 2023, 2.5-year safety and clinical efficacy results from the long-term extension study were presented. I've already gone over the design of that study. There was a treatment gap, which was a variable length for different participants as part of the study, and that had to do with the transition from the double-blind to the open label study, as well as the placebo run-out. There were no new safety signals at week 120. The most common adverse events were COVID-19, headache, nasopharyngitis, upper respiratory infection, and then some other conditions with less than 10% prevalence in the group. The annual relapse rate remained low at about 0.2 at the long-term follow-up. About 3/4 of the participants remained relapse-free, and the mean disability scale, the EDSS, remained stable out to week 120. A subgroup analysis was also presented at AAN 2023 at week 96. These were individuals with highly active disease at baseline. That meant that they could have either at least one gadolinium-enhancing lesion within the 6 months prior to entry into the study, 9 or more T2 lesions in the brain at baseline, or 2 or more relapses in the prior year. About half of the participants in the study met one of these criteria, and 92% of them remained in the study as of the cutoff time for this analysis. Again, parameters related to lesions, gadolinium-enhancing and T2 lesions, as well as relapses and disability were measured. And in this cohort, the annual relapse rate was 0.1. 93% remained relapse-free, and the mean disability scale, EDSS, remained stable out to week 96. The new and enlarging lesions remained low, and the safety profile was similar in the highly active disease group. The MRI data were also presented at AAN 2023. These included the number of new gadolinium-enhancing lesions or enlarging T2 lesions, the change in the T2 lesion volume, the slowly expanding or slowly evolving lesions, as well as paramagnetic rim lesions. So with respect to the slowly expanding lesions, which again are thought to be, at least in part, reflective of chronic inflammation within lesions that doesn't resolve, there were no clear differences between the treatment group And with respect to paramagnetic rim lesions, which are lesions in which there is a rim of iron-containing microglia at the edge that are visible on high-field MRI scans, indicating chronic inflammation in the brain. Only a subset of the participants had this analysis, which requires some specialized MRI hardware and software. The count of such lesions was unchanged in 18 patients who had the analysis. 2 patients had at least one such lesion at baseline that then resolved, and 3 had a few new lesions, and these were all lesions that appeared on trial. And these chronic inflammatory lesions, known as PRLs, occur in the wake of new lesions. So they weren't old lesions that had become inflamed, but rather new lesions in which inflammation was persistent. But for the most part, there was stability of the paramagnetic rim lesions. There was also a study reported at the recent ACTRIMS meeting in 2023 looking at cerebrospinal fluid and plasma concentrations of Talibrutinib in healthy volunteers at either 60 milligrams, which is the phase 3 dose, or twice that, 120 milligrams. Talibrutinib was detected in the spinal fluid at all time points for both doses, reflective of its ability to cross the blood-brain barrier. And the doses were expected to have an impact on microglia, and providing proof of concept for the notion that some of the impact of Talibrutinib may be related to its effects inside the brain and not just in the peripheral immune system. Let's think now about future considerations with respect to BTK inhibitors in multiple sclerosis. Here's the current landscape of phase 3 clinical trials of BTK inhibitors in the brain. There are 4 in trials: Evobrutib, Talibrutinib, Fenebrutinib, and Remibrutinib. Evobrutib is being trialed in 2 phase 3 studies where the primary outcomes are expected to be completed in 2023. This includes patients with relapsing or secondary progressive multiple sclerosis with relapses, and the trial is ongoing but fully enrolled. Talibrutinib is being studied in 4 phase 3 trials, 2 in relapsing multiple sclerosis with an active comparator in teriflunomide, and 2 in progressive multiple sclerosis, primary progressive MS, the Perseus trial, and non-relapsing secondary progressive MS, the Hercules trial. And these are ongoing with expected completion dates in the not too distant future. And then Fenebrutinib is being studied in relapsing MS in 2 phase 3 trials against teriflunomide, and in primary progressive MS against ocrelizumab, a CD20 monoclonal antibody. And the anticipated completion dates are in 2025 and 2026. And then finally, Remibrutinib is being studied in relapsing multiple sclerosis with the comparator of teriflunomide, with a 2026 primary outcome date expected. It's very important to discuss, with respect to BTK inhibitors, significant regulatory events that have occurred over the past year. That is the partial clinical holds on both Talibrutinib and Evobrutib from the U.S. Food and Drug Administration, the FDA, in response to evidence of drug-induced liver injury. It is not surprising that BTK inhibitors have some impact on the liver. And in June 2022, the FDA placed a partial clinical hold on the phase 3 Talibrutinib trials, indicating that there should be no new enrollment. The study drug was suspended in those with less than 60 days of exposure. However, other regulatory agencies allowed continued recruitment, and that did go on in these trials. The events, again, all occurred early in the treatment, and so patients who had been on drug for more than 60 days were allowed to continue. And then much more recently, in April 2023, there was a partial clinical hold on the phase 3 Evobrutib trials for patients with less than 70 days of exposure. However, the trial was fully enrolled and all participants were on treatment for more than 70 days, and so they were allowed to continue. And the reports of severe drug-induced liver injury are sparse, and data are still being collected and reported on this. So with respect to differences across the BTK inhibitors, we can think about the impact of along a variety of axes, the domain target within the kinase, the selectivity, the tolerability, the dosing regimen, the reversibility of the inhibition, the binding, covalent versus non-covalent, and then very importantly, if we want to modulate chronic inflammatory processes in the brain, CNS penetration. I think data on the different BTK inhibitors with respect to along these various axes is still emerging. Are there meaningful differences across molecules in the BTK inhibitor class? Yes, very much so. We already know about differences with respect to the mode of binding and the CNS penetration. But we don't fully know yet what the impact will be clinically with respect to efficacy or safety. But let's think a little bit more about what the potential impact could be. So can BTK inhibition alter the phenotype and function of myeloid cells? And at the ACTRIMS forum in 2023, some data were presented in this regard. In human whole blood pretreated with Evobrutib or Talibrutinib, inflammatory cytokines, including TNF and IL-6, were decreased. And this was also the case in human bone marrow-derived macrophages. There was also evidence of increased phagocytosis after BTK inhibitor treatment, which may indicate improved ability to repair MS-associated damage within the CNS. And after potent inflammatory stimulation with lipopolysaccharide, TNF was decreased in Talibrutinib-treated cells, but not Evobrutib-treated cells in this study, again suggesting some heterogeneity of effects in these non-clinical studies. In another study, proteomics in the cerebrospinal fluid were assessed in Talibrutinib. This is a study of nearly 1,500 proteins using the Olink proteomic platform in a variety of participants, including untreated multiple sclerosis compared to healthy volunteers, as well as patients in a trial in which patients with evidence of paramagnetic rim lesions at baseline who had been taking ocrelizumab and then were switched to Talibrutinib were studied. And what was found is that over the course of this study, some disease-associated proteins were modulated towards levels observed in healthy volunteers, and then very importantly, some protein levels, including neurofilaments in the spinal fluid, were decreased in the setting of Talibrutinib treatment out to 48 weeks after transitioning from ocrelizumab. So how would we use BTK inhibitors in clinical practice? I think evidence is emerging from the phase 2 studies that it is likely to have an impact on relapsing multiple sclerosis, and should these drugs eventually be approved, will become part of the armamentarium that we have with respect to relapsing multiple sclerosis. We're still gathering data with respect to efficacy in progressive MS, and in particular non-relapsing progressive MS. And we will need to understand where in the treatment course these drugs should be used. And that, of course, is a balance between efficacy and safety. Combination therapy, perhaps with B-cell inhibition, may be an option down the road. Indeed, in tumors, in which BTK inhibitor are being used, they are in fact combined in many cases with CD20 inhibition. So that may represent a possibility in the future. And then one of the things that, of course, will be on people's mind is whether discontinuation of a BTK inhibitor could result in rebound. And in fact, there is some data already on this. At the American Academy of Neurology 2023 meeting, data were presented looking at the 4-week run-out period in the phase 2b study of Talibrutinib. And this allowed, at least over a short period of time, assessment for rebound activity following discontinuation in the cohort 1, who had 12 weeks of Talibrutinib, followed by 4 weeks of placebo, unlike cohort 2, where that was flipped. And preliminary findings reported suggest that discontinuation of the study drug did not induce rebound disease activity. However, longer observation periods are needed to validate findings. So just some thoughts as we close. Greater understanding of the role of B cells in multiple sclerosis, as well as microglia and other myeloid cells, has led to the exploration of BTK inhibition as a potential avenue for multiple sclerosis that could work both potentially for some of the molecules, both in the periphery and in the central nervous system. 4 BTK inhibitors are currently in phase 3 trials for multiple sclerosis, both relapsing and progressive multiple sclerosis, and readouts are expected to begin later this year. So stay tuned for data on those. And I think the different molecules have different properties, and so the distinctions among the members of the BTK inhibitor class will be really important in guiding treatment decisions in the future. Thank you for participating. I hope you found this activity informative and useful as we think about new avenues in MS care and the potential utility of BTK inhibition.
This activity is certified by PVI, Peer Review Institute for Medical Education. Remember to download the slides. Thank you for listening. Download materials and complete the post-test for instant credit at peerreview.com/TFV860. This activity is supported by an educational grant from Sanofi.